Hello, I'm Doug Muzzio. This is the first of several shows dealing with major issues of the 2008 presidential election. Today, nearly 50 million Americans have no health insurance. Another 25 million American adults are underinsured. That's 75 million adults. 42% of the under 65 population has either no insurance or inadequate health insurance. The American health care, disjointed, expensive, with inferior quality, limited and declining access, a non-system in perpetual crisis. To talk about the state of U.S. healthcare, particularly the widespread lack of adequate insurance and the campaign stances of both Barack Obama and John McCain, is Dr. Sara Collins, Assistant Vice President at the Commonwealth Fund, a foundation dedicated to health policy, health reform, and performance improvement. Dr. Collins runs the fund's program on the future of health insurance. Prior to joining the fund, Dr. Collins was Associate Director and Senior Research Associate at the New York Academy of Medicine. Welcome, Sara.
Thank you.
Talk to me briefly about what the Commonwealth Fund is and what this program on the future of health insurance is all about.
Okay. The Commonwealth Fund is a private foundation that was established in 1918 by Anna Harkness.
Wow.
Its mission is to promote a high-performance healthcare system to achieve higher quality, better access to care, more efficient care, particularly for vulnerable populations, low-income families, uninsured, minorities, young children, elderly, adults. In 2005, the Commonwealth Fund established the Commission on a High-Performance Healthcare System, also charged with increasing the level of performance in the healthcare system. It's comprised of about 19 members, experts from all over the healthcare system, business leaders, leaders of academic societies, federal and state policymakers.
And you run this program for the future of health insurance, so you've got a piece of this larger healthcare issue and problem.
That's right. So I direct the program on the future of health insurance. We're focused on the extent to which people are uninsured and the extent to which that makes a difference in terms of their access to health care, their financial situation, and what can be done about it. What policies could we impose on the system to reach greater coverage, better access to care? You've
done a number of reports, both by yourself and in conjunction with others. The October 7 report, Roadmap to Health Insurance for All, really lays out the criteria of what a good health system could be and provides some indication of how to measure whether we're meeting those criteria. Talk a little bit about how we should measure the healthcare system and particularly how we should assess the situation of health insurance in the United States.
Well, the Commission on a High-Performance Health System has identified extending health insurance coverage to everyone as a key component of reaching a higher
so that's part of the institutional goals.
That's exactly right. It's not a sufficient condition, but it's certainly a necessary condition for moving the system to overall higher level of performance. Other strategies would include aligning incentives to improve quality and efficiency, organizing the delivery system to achieve more coordinated care, performance measurement, evidence-based medicine, establishing some national leadership on. But the coverage piece is very critical to moving the system to a higher level.
So this is a sine qua non. If you don't increase the coverage, if you don't increase increase the access, you can't increase the quality. There's a causal relationship you're suggesting.
Absolutely. I mean, the Institute of Medicine has identified health insurance coverage as the most important determinant of access to health care. Without it, people don't get the health care that they need. There's a huge body of evidence now showing that people aren't able to manage their chronic conditions, aren't able to get preventive health care, aren't able to get immunizations. Children don't get immunizations. So
large numbers forego absolutely necessary care.
That's exactly right. So the fund just released a paper in Health Affairs looking at people who were either uninsured for a time during the year or who had such high out-of-pocket costs relative to their income that they were essentially underinsured. And what we found is that more than 2/3 of people who were uninsured for at least some time during the year, more than half of people who were uninsured for a time during the year didn't get needed health care because of costs. They didn't fill prescription medications. They didn't see physicians when they were sick. They didn't get follow-up care tests that they needed when it was recommended by a doctor. So big gaps, and you see that across all studies that are done on this issue, and we lag way behind other countries on this measure.
So we can't boast, we meaning the United States, boast that we offer the highest quality care in large measure because of the large number of people who are inadequately covered?
That's right. So it used to be that we could claim that we had the best health care in the world, but what the Commission, the Commonwealth Fund Commission on High Performance Health System, has discovered through this large scorecard that it's done, measuring the performance of the healthcare system across 37 measures of access, quality, efficiency, equity, health outcomes.
And it's impressive. I mean, you've got 5 key areas, and under those areas you have specific performance measures. I guess the doctrine is if you don't have the data and you don't know if you don't measure, you don't know what you're doing.
That's exactly right.
And it seems to be endemic in the system that we simply don't know what we're doing.
Right, exactly. So this is really one of the very first efforts to measure where we stand relative to other countries, other industrialized countries that have universal health insurance coverage, like France, Germany, Japan, looking at how we rank on measures of deaths that are preventable. For example, preventable deaths from diabetes, from heart disease. We rank last among 19 countries overall on preventable deaths. If we were to increase our performance, we could improve the life expectancy of the population, decrease 100,000 deaths per year if we can move to a higher level of performance.
And that in a sense is only the human cost. I mean, looking at only the human cost. The fiscal savings are obviously in the tens of billions of dollars.
That's right. So we don't, because we don't insure people wait too long to deal with their chronic conditions until they're very serious. They end up with very serious chronic conditions. A study that was done by Michael McWilliams at Harvard found that uninsured Medicare beneficiaries who were uninsured prior to joining Medicare had much higher rates of health system use after entering the Medicare program than their insured counterparts, people who had insurance continuously before entering Medicare. So much higher expenditures when they entered Medicare simply because they hadn't been able to deal with their heart disease or diabetes before they got into the program.
The old maxim about an ounce of prevention worth a pound of cure.
That's right. So could we cover those people with the savings that we got from the Medicare program, covering people beforehand?
Let's talk about the coverage. We talked about two numbers, 47, 50 million people without insurance, and another 25 using the criteria established by the fund being underinsured, for a total of 7. The numbers are going up since you began the study. Why? Right. Why do you have significant increases in both those not having insurance and those who are underinsured?
Well, what we're seeing over time is galloping healthcare costs. So we know that healthcare costs are running way ahead of growth in health and other indicators in the economy, growth in GDP, growth in wages. Employers are struggling to provide health insurance to their employees because of growth in premiums. And so they're either dropping coverage altogether, so people are becoming uninsured, or they're increasing deductibles, increasing copays, increasing the costs that people have to spend on their premiums, on their health insurance coverage. So people are becoming either uninsured, more people are becoming either uninsured or having such high out-of-pocket costs that they're effectively underinsured. The other dynamic that's important to remember is that income growth has been extremely sluggish over the last 5, 6, 7 years. The minimum wage is now worth $3 an hour less than it was 40 years ago. So as healthcare costs are rising very quickly, incomes just have not kept up. So people are experiencing now rising gas prices, decline in housing prices, food prices, and healthcare costs is one of those things that working families are trying to deal with right now.
You mentioned the employer bought insurance. Talk about the nature of this sort of disjointed, crazy quilt system that we have in the United States and how it tends to differ from other, developed democracies, if you will.
Well, we have an extremely fragmented health care system and health insurance system. I mean, 55% of the population, about 160 million people, get coverage through an employer. Another 13% get coverage through the Medicare program, 9% coverage through the Medicaid and SCHIP program, State Children's Health Insurance Program, and 16% are uninsured. Only 5% of the population gets coverage through the individual insurance market. We have a voluntary employer-based health insurance system. So if your employer offers you coverage, you're probably going to have coverage.
Right.
If your employer doesn't offer you coverage, your options are very limited. Medicaid and SCHIP have been very effective at covering children. We've seen a decline in the number of uninsured children across many states over the 10-year period of the SCHIP program, for example. But we've seen a steadily increasing rate of uninsurance among adults, simply because there's no place for adults to go other than the individual insurance market. So the individual insurance market underwrites. If you have a pre-existing health condition, it's very expensive to get coverage. You don't get a premium contribution from your employer. So we just have gaping holes in the system where people, if you lose coverage through an employer, if you lose coverage through a public insurance program, you just really don't have an affordable place to go.
What does it mean to be underinsured?
The Commonwealth Fund developed a measure based on its health insurance survey, the biennial health insurance survey that we do every 2 years. Whether did you have health expenses that exceeded 10% of your income, not including premiums.
Okay, so there's some kind of income trigger.
Right. So we asked people what their out-of-pocket costs were. We asked people what their income is, and then we measured if you were considered underinsured, if your expenses exceeded 10% of your income. If you're a lower income, if your income was only 200% of poverty or less, we determined that you're underinsured if your costs were 5% or more of your income. If your deductible was more than 5% of your income, we counted you as underinsured.
So you're fairly confident that your measure actually taps into a concrete reality out there that has significant health impacts on the individual as well as impacts on the system.
If anything, we underestimated the number of underinsured because we only know what people's costs were during the year. We don't know the extent to which people are potentially underinsured. We don't know if people have caps, lifetime caps, that would leave them potentially underinsured if they had a catastrophic illness, for example. So we only know what people reported, what the healthcare costs they reported during the year. So we probably are underestimating the number of people who are effectively underinsured. And the interesting thing is that people who are underinsured behave very similar to people who are completely without coverage or had gaps in coverage during the year.
Explain this behavioral dimension.
Well, we asked people, did you avoid health care during the year because of cost? Needed health care? Did you not fill a prescription because of cost? Did you not go to the doctor because of cost? And
behaviorally, it's similar.
Yes, about 2/3 of people who were uninsured during the year said yes to any one of the questions we asked on cost access problems. About more than half of people who were underinsured reported any one of those problems. Also in the areas of finances, did you have problems paying medical bills? Mm-hmm. Did a collection agency contact you about not being able to pay a bill? We find very high rates among both people who are uninsured, underinsured, 50%, almost 50% among underinsured.
And we're seeing these numbers increase.
And we're seeing these numbers increase. Access problems definitely on the rise. We're seeing between 2003 and 2007, definitely an increase in access
And
problems.
without interventions, it will increase further?
Well, the concern is that we looked at a period of time when the economy was actually expanding. There was some growth in the economy. Incomes were very sluggish, but there was growth in the economy. What's concerning now is that we're on the brink of what could potentially be a very serious recession. So are more people going to lose access to employer-based health care, health insurance? Are more people going to be shouldering a larger share of the cost of their health insurance as employers struggle with this issue?
Let's turn to the two major candidates and their positions on the various elements of health care and health insurance, and talk about what in the Commonwealth Fund's thinking would be the preferred approach to healthcare. Talk about the similarities and differences between Obama and McCain. You and Jennifer Criss in January wrote a report looking at all the 2008 presidential candidates entitled Envisioning the Future, the 2008 presidential candidates' health reform proposals, and you're revising it to focus in on McCain and Obama. Talk about the differences in the quote-unquote Republican and Democratic approach, and then more specifically the comparisons between the McCain and Obama approach.
Okay. Well, Senator McCain has proposed eliminating the employer benefit income tax exemption. So right now, when you get coverage through your employer, your premiums are not taxable income to you. He would change that so that premium contribution does become taxable income, but he would replace it with a tax credit, which you could apply either to employer-based coverage.
So he's trying to eliminate, essentially, the employer-based insurance approach, isn't he?
He is definitely trying to move away from the employer-based system towards more individual. He describes this as a way of providing people more choice. People would have more choices. They could choose either an employer-based plan or they could go buy coverage on the individual insurance market.
The belief that you open it up to the market and greater competition produces desired outcomes. Right. Sort of, if I may, voodoo healthcare. I mean, you don't have to make that value judgment. Go ahead.
And he would also allow you to take your tax credit. It's $2,500 for an individual, $5,000 for a family. That's what he's proposing. You could take that tax credit and you could buy individual market insurance in any state. And that's a big change as well. Right now, you have to buy in the state that you live in.
Right.
The important thing to note about that is that some states, like New York, have community rating, guaranteed issue, so they protect consumers.
And in New Jersey as well.
And in New Jersey as well,
right.
Massachusetts.
Right.
But states like Texas, Iowa don't have strong community
ratings. So the
ratings.
federal law would supersede local law and therefore weaken protections?
That's what he is proposing. And what you can envision this is the likely scenario. So people who are healthier would gravitate towards states that don't have protections because they could get lower premiums. People who are less healthy would gravitate to states like New York where they could get more, they would be more likely to get coverage.
So you would really have separate but unequal systems?
You could have a situation where the risk pools are so fragmented that it would ruin the risk pool essentially in the state of New York. Okay. So too many unhealthy people, insurers would be much less inclined to provide coverage.
Okay, so on one hand, you've got the McCain Republican approach, which is basically individual choice and tax incentives. What about the sort of the Democratic/Obama approach, even though there are differences among and between the Democrats?
That's right. Well, Senator Obama is proposing to build on our current system. This
sort of mixed public-private.
Right, exactly.
Okay.
Exactly. So he would maintain the employer role in the system. He would require employers to provide coverage to their employees, or if they didn't provide coverage to their employees, they would pay a payroll tax that would go towards supporting what he's calling a national health plan, a national health insurance exchange. So he's basically would fill that gap that I mentioned earlier in the system where people lose coverage through an employer, they don't really have a place to turn to. He would reorganize the individual insurance market, regulate it, so apply the community rating that New York State has, for example, guaranteed issue. He would establish a standard minimum benefit plan, so there'd be a floor in terms of benefits.
And McCain doesn't provide any.
McCain does not do that. No,
okay.
He does not do that.
The Obama Democrat approach sounds like the Massachusetts model.
It's very similar in structure.
And explain what that means.
The Massachusetts has established the Commonwealth Connector. They also have an employer mandate. Employers are required to provide health insurance coverage. The difference between Obama and Senator Obama's proposal and the Massachusetts plan is that everyone in Massachusetts is required to have health insurance. So you have to have...
It's mandated.
It's mandated. So you're required to have... If there is an affordable plan, what they consider to be an affordable plan, then you are required to enroll in a plan.
Now, Obama doesn't do that. He just has it mandatory for children.
He would just mandate children.
And McCain doesn't have it mandatory for anybody.
That's right. That's right.
What about coverage? Is the aim of the Obama plan to ultimately cover everyone? And is that the case in the McCain plan?
McCain is proposing to expand health insurance coverage. Senator Obama is proposing universal coverage. Whether or not either can achieve that, it really depends on the details of their plans. Another key part of Senator Obama's plan is he would increase the eligibility levels for the Medicaid program, increase it maybe to 100% of poverty, though he hasn't really stated what those details are.
Which would increase the pool of available folks to get public.
Exactly. So very few adults, for example, without children are covered in the Medicaid program. 34 states don't offer coverage for adults without children. So he would increase that eligibility as well. He would also offer premium subsidies. So if you couldn't afford, if you had low income, you could take your premium subsidy and buy a plan in this national health insurance exchange that he is proposing. And you'd have the option of a public plan, or a private plan through this national health insurance exchange. Now, the state of Massachusetts has a similar newly regulated, reorganized individual insurance market that it calls a connector. So people who are mandated to buy coverage, if you don't have it through your employer, you can buy it through this new connector, which is similar to Senator Obama's exchange that he's proposing.
Okay. Now, what are the similarities here? It seems that you really do have a stark choice here in terms of both philosophical approach as well as practical implementation here. What are there similarities?
I mean, the main similarity, I think the central observation is that, and this has been true across the election, is that everyone is talking about building a system around existing private insurance markets, with the exception of Congressman Kucinich,
right,
who proposed a single-payer plan. Most candidates have been talking about reorganizing the individual insurance market, moving more people towards the individual market in the case of the Republicans.
Given the goals, the core principles and goals of the Commonwealth Fund, it seems that the Universal Kucinich plan is the plan that had the potential of most extensively meeting those goals, and that the mixed system certainly is a step there, but not there in given your values, or the Commonwealth Fund's values.
Well, the Commission on a High-Performance Health System set up a set of principles for health reform. The health reform plan should cover everyone, for example. Benefits should cover essential services with appropriate financial protection. Premiums, deductibles, out-of-pocket costs should be affordable relative to family incomes. Risk pools should be broad. So we want to move to a system where people are in very large pools, like large employer plans. Those have worked very well so far because health risks are pooled across the age spectrum, across health status. And we also want a system where people, it's easy for people to get in. It's easy for people to stay enrolled, to stay continuously enrolled, automatically enrolled. We want a system where people where the financing is shared. So employers have a financing responsibility, individuals have a responsibility, and the government has a responsibility. And polling of the public really does show that they also view that this is a shared responsibility. Right. And so, in terms of the health plans, if you setting those principles up against what the candidates are proposing, certainly a single payer system would be the simplest to administer. In microsimulation modeling of single payer systems like Medicare for All, you get huge savings in administrative costs. It's easier to measure quality if everybody is in the same system. The more fragmented a system is, the less leverage you have to impose things like pay for performance, for example, changing the way we pay providers. It would be easier under a single payer plan.
But clearly the fragmented system benefits certain interests and certain stakeholders at the expense of other interested parties and stakeholders.
Yes, and you also have to think back, I mean, in terms of the politics of this. So if you think back to the Clinton administration's proposal,
right.
People were going to have to move from what they had to another way of getting coverage. 160 million people, 60% of the under 65 population has coverage through their employer. Most people, polling shows that most people
right.
do like their coverage.
Right.
So the idea of moving to a new system, what that entails, people having to, increases the fear factor of moving from what you like, what you're comfortable with, to something new and unknown. So moving towards something where we can at least fill the gaps in the system, people can keep what they have, but fill the gaps, establish some standards, try to look at ways we can improve quality as we get everybody into the system. At least it's a first step towards getting everybody into the system.
You are named President Obama's health advisor. What are the first things that you would advise him to do?
Well, I would think this is high on the nation's agenda. Healthcare is high on the nation's agenda. People are hurting right now. We're seeing, large numbers of people not getting access to care, medical bill problems, et cetera. So I would think that this needs to be tops on their agenda. Certainly, it competes with a lot of other issues facing the country.
What's the first thing you do? Concretely, what do you propose to Congress?
Well, I think that his proposal, he set up a framework, and I'm certainly not a political advisor, so there are political issues that,
right.
that other experts would be much better
just
at.
be a policy advisor. Forget about the politics.
Yeah, right. Well, I think the what he's proposing. There's lots of lessons to be gained from Massachusetts. There's a lot of tweaking that needs to happen. We need to think about how you would implement a connector or a national health insurance exchange on a national level. I don't think that there's been a lot of work on how that would actually work.
Okay.
How would you get insurance companies, for example, to take? We want insurance companies to compete not on risk anymore. We want insurance companies to compete on the basis of quality. We want insurance companies to take people with chronic disease and help them manage their diabetes, help them manage their heart disease. Right now, the incentives aren't aligned that way in the system. We want to change the dynamic in the system, and a lot of that could happen in the Medicare program, but it could also happen. I mean, not so much in the Medicare program, but could happen in the national and such a connector or national health insurance exchange.
So the bottom line in all of this is that there really are a lot of unknowns, and that we've got these plans, these approaches, but they remain that, plans and approaches, and they're fragmentary at best, and we really don't know a lot of what's going on out there.
Well, we know it works. We do know that large employer-based plans work pretty well. We know that the individual insurance market works very poorly. So focusing on strengthening what works, fixing what doesn't work in the health insurance system would probably be and I think that's where the conversation really is. There's been a coalescence around thinking about how we go about keeping what works, improving what doesn't work.
Thank you. Hello, I'm Doug Muzzio. Let us know what you think about this show. You can reach us at CUNY.TV. When you get there, click on the bar that says Contact Us and send your email. Whatever it is. Thanks, no thanks, obnoxious, do it. Send it.